Bismillahirrahmanirrahim. Good afternoon, everyone. First of all, I would like to thank Pakistan Society of Endocrine and Thyroid Surgeon Association, President Professor Khaja Azim, and Dr. Talat for their kind invitation and giving me this opportunity to talk on this important subject. And I congratulate them for holding such a wonderful virtual conference in this difficult time of pandemic. So today's my topic of discussion is management of esophageal perforation. So esophageal perforation is a serious but rare injury, and iatrogenic injury is the leading cause of esophageal perforation, constitutes 60% of all esophageal perforation. And in traumatic injuries, we sometimes see esophageal perforation, and penetrating injuries are more common. And out of penetrating, previously it was the stab, and now it's the firearm injuries with sometimes patient present with esophageal injuries. So blood injuries constitute only 1/10% of the penetrating injuries. So now esophagus is a well protected organ, and in the upper thorax it is behind the trachea, and in the lower third it is in close association with the arch of aorta and aorta. And because of its location, uh, it is usually safe in the blunt thoracic injuries, but we must be suspecting esophageal injuries, and we must rule it out by appropriate investigations. So iatrogenic, with the endoscopic, more and more endoscopies we are having, so it is associated with esophageal perforation. Although it's rare, it is less than 0.03, but still, considering the volume of endoscopies, iatrogenic perforation is still the number one cause of esophageal perforation. And out of various procedure, endoscopic dilations and endoscopic procedures, structure dilations, and endoscopy for diagnostic purpose, to all have this some contribution. So in trauma, we see esophageal injuries, and it is usually associated with the penetrating injuries like firearm injuries or sometimes stab injuries. And a third condition that is known for more than 200 years ago is a spontaneous perforation of the esophagus. So spontaneous perforation after forceful vomiting, if the patient develop, that is also called Boerhaav syndrome, is associated with severe chest pain, emphysema, and unwell patient. If it is in the history of recent forceful vomiting, any condition that raised to increase thoracic pressure can lead to Boerhaav syndrome or spontaneous perforation of the esophagus. And then the foreign bodies. Ingestion of foreign bodies is common in children, especially the sharp object and the batteries, all can lead to perforation of the esophagus. And then sometime rarely the tumor of the esophagus can present as perforation of the esophagus, and some peptic ulcer at the lower end of the esophagus. And in this part of the world, corrosive intake is one of the known cause. Patient with a history of corrosive intake can present with esophageal perforation. So now we go through the epidemiology of the esophageal perforation. So statistically, 27% are the cervical esophagus injuries, and these are usually instrumental. And then intrathoracic, 54%, and 19% are intra-abdominal perforation that present as a peritonitis. So we briefly discuss what happens after esophageal perforation. We know esophagus is sometimes full of food, secretions, and sometimes acidic secretions. When there is a perforation, there is a contamination of mediastinum, and if it is breaching the pleura and entering into the pleural space, so it causes severe chemical inflammation initially and soon followed by bacterial contamination. So it results in mediastinitis and pleural effusion, and further by bacterial colonization result in sepsis, multiple organ failure, and if left untreated, is associated with high mortality, and ultimate outcome is death. So Boerhaav syndrome was described by the Boerhaav 200 years ago in a king who developed severe chest pain and emphysema after alcohol intake and forceful vomiting. So, triad of clinical symptoms, vomiting, chest pain, and emphysema is diagnostic of esophageal perforation, especially when there is a recent history of forceful vomiting or any other violent coughing, and sometime in females after during delivery, any it can result in esophageal perforation. There are case reports. Here's an interesting case that I like to share with you. So we received a patient who presented with a few hours history of firearm injury. So you can appreciate very well a patient sitting up and about, hemodynamically stable, and with a small entry wound at the left sternoclavicular joint. And after passing a nasogastric tube, so when they insufflated the air, so you can see the air bubbling in the esophagus. So when we are suspecting clinically esophageal perforation, so what investigation we should be getting? CBC and CRP is to see actually the degree of inflammatory response and infection. So radiology is the mainstay of investigation. So first we get to the routine plain X-ray chest and neck APN lateral views. So we may see free gas into the mediastinum or in the neck in the subcutaneous plane. And if there's a doubt, then we can proceed for contrast esophagography. So there's a controversy. Some people say that it can sometimes worsen the mediastinitis, but routinely we use contrast study, and extravasation of the dye can confirm the esophageal perforation. CT chest, so X-ray neck and chest, APN lateral, and when we are suspecting abdominal esophageal perforation, so we get an X-ray abdomen to see any free gas under the diaphragm. So here we see free gas in the mediastinum and in the neck. Water soluble contrast. If there is nothing on the water soluble contrast, then we can go for thin barium swallow study. And here in this esophagogram, you see extravasation of the dye quite clearly seen. So in this modern era, CT chest with contrast, oral contrast, is the gold standard investigation for confirmation of the esophageal perforation. We can clearly see it is 92 to 100% sensitive to diagnose esophageal perforation. We can see the extravasation of the contrast here. So in the diagnosis, high index of clinical suspicion is very important whenever we are dealing with any thoracic injury after especially the history is obvious. If the patient has an endoscopy or endoscopic procedure in the recent, after that, if the patient develops chest pain, emphysema, it's quite specific that we must be suspecting esophageal perforation. So what are the different management options? So most important thing is whenever we are suspecting a patient with esophageal perforation, we must admit the patient in the ICU setting, and patient are usually sick, unwell, needs resuscitation, and then we can plan what is the option in this patient. Obviously, we have to decide whether we have to go for non-operative management or patient needs immediate surgical exploration or some sort of endoscopic management. So these are the factors that actually affect or help in planning a management plan. So what is the etiology? Second thing is, what is the location of the perforation? Because options are different if it is in the cervical esophagus, in the upper middle third of the esophagus, or in the lower third of the esophagus. And third thing important is, what is the time interval between injury and presentation. If it is less than 24 hours, there is a less mortality, and if it is more than 24 hours, it is associated with high mortality. So what is the criteria for non-operative management? If there is, let's suppose patient had an episode of vomiting and there is a mild chest pain with emphysema, but there is no clinical sign of sepsis. And second condition is if there is a perforation, it is draining back into the esophagus, if it can be demonstrated radiologically. And third thing is a small perforation limited only to the mediastinum, there is no visceral pleura breach, and there is no penetration into another cavity. So non-operative management includes resuscitation, NPO, parenteral or enteral nutrition, and broad spectrum antibiotics and analgesia. And if there is a pleural effusion, then the chest intubation may be placed. Endoscopic management. Endoscopic treatment is a gold standard for closing esophageal perforation that occur are recognized during the endoscopic procedure. That's very important. If you are performing an endoscopic procedure and there's a perforation, and if the skill and expertise are there, the perforation can be repaired there by endoscopic suturing or endoscopic clipping. And this is with good outcome, and there are few publications that supports very good outcome with endoscopic management of these injuries. And sometimes endoscopic management is alone done by the endoscopist, and while sometimes if there is a adjacent collection, the procedure can be performed in collaboration with the interventional radiologist. And these are the three options. One is the endoscopic clipping. Second thing is sometimes for large perforation occurred during endoscopy may be managed by covered metal stents. And third thing is endoluminal vacuum therapy. Okay, endoscopically, if there's a perforation and it's communicating with some adjacent cavity, a drain can be placed into the abscess cavity or in the collection, and then through a suction system, it can be drained. So what are the indication for surgical management? So first of all, if there is a esophageal perforation and time period is less than 24 hours, we must think of surgical exploration. Second set of patient is the one who after esophageal perforation are sick, unwell. So though they definitely after resuscitation, they need some surgical exploration. Recent post-emetic perforation. You know, the post-emetic perforations are with more morbidity and mortality than the endoscopic because there is a more contamination. The esophagus is full of food contents, and it results in more contamination and more morbidity and mortality. So if the patient is having feature of sepsis and there's a perforation, it should be surgically repaired. Third thing is, if the as a matter of principle, if there is a documented esophageal perforation and patient is fit to undergo a surgical procedure, the surgical exploration must be considered because there is no place for conservative or medical management in an established esophageal perforation in a fit patient. And third thing is, if there is a distal obstruction because of the malignancy, corrosive structure, so then that perforation is not going to settle with medical management. Those patients should be considered for surgical exploration, considering as patient malignancy, the stage of the disease, and possibility of resection. Third thing is, okay, whenever you come across a patient where you're suspecting esophageal perforation, after resuscitation and assessment, patient should be transferred to the hospital where there is an experienced surgical team, good ICU facility, intensivist, because esophageal perforation needs to be managed by in an MDT way, and where all the diagnostic and therapeutic ICU and surgical expertise are available. So these are different surgical options that we can consider in a patient with surgical esophageal perforation. The first thing is, sometime for small perforation, and if there is a pleural effusion, sometime tube thoracostomy is the treatment that is required. Other is in case of fresh injuries within 24 hours, sometime only primary repair of the esophagus is required. So after exploration, primary repair in a single layer or two layer can be offered. Third thing is if the injuries are large and old, more than 24 hours, then the primary repair is unlikely to stay. So these repairs needs to be reinforced with some adjacent healthy, well vascularized tissue. This can be pleura, intercostal muscle, diaphragm, sometime pericardial sac or pleural flap. And if the tissues are not healthy and not amenable to repair, sometime diversion, proximal diversion is the what is required in the management of these patients. And in few conditions, esophageal resection like cystic structure, malignant obstruction, sometimes esophagectomy or esophageal resection is what is required. And in certain situation, esophageal endoscopic esophageal stenting is required. That is actually has a now more and more use of endoscopic techniques is being used. Esophageal stenting is useful for small perforation where there is no major contamination or peritonitis or mediastinitis. And on the other side, in a patient where there is a large perforation and patient is not fit for major surgical procedure, so then here covered stent can be placed along with drainage of the chest cavity. And lastly, endoscopic endoluminal negative pressure therapy. So now we talk about the specific situation that we encounter in the management of esophageal perforation. One is repair of the cervical esophagus because cervical esophagus injuries are common. So surgical exploration is easy. So primary closure and drainage of the neck, that is what is required in majority of the patient if they present within 24 hours. And this is the approach in seen along the left anterior sternomastoid, and then mobilization of the cervical esophagus, debridement of the perforation site, and repair in single or double layer depending upon the situation. Some people advocate the mucosa should be repaired separately and then the muscle, and there are few reports with the comparable results. We can repair in a single layer. And then buttressing of the repair with sternomastoid flap may be required. And whenever we are dealing with esophageal injuries, so one is we have to pass the nasogastric tube across the repair for drainage and for nutritional purpose. And in case we have done the laparotomy for some reason, so then feeding jejunostomy can be done, especially when the injury is late and we are anticipating post-operative leakage. So these are the few images. So in case of the esophageal perforation, we may perform a local debridement and then repair of the mucosa and muscular layer. And sometime if the tissues are not healthy and you are anticipating leak, so then the repair can be done and the T-tube for decompression may be placed. Here is the case like Boerhaav syndrome in the perforation in the distal esophagus. So perforation of the distal esophagus needs to be accessed through left thoracotomy. Lung is retracted, debridement of the tissue is done, and then repair of the perforation is done. And if the tissues are unhealthy, then the reinforcement with the intercostal muscle flap or pleural flap can be done as shown in the figure. And sometime, especially in the cervical esophagus or mid-esophageal injuries where repair is not possible, simple or as a damage control measure, diversion of the cervical esophagus can be done. And proximal esophagus can be brought out as an esophagostomy. till the time patient is out of sepsis. Then the definitive surgical plan for the restoration of the GI tract can be done later on. So if there is some injury in the upper thoracic esophagus, so for upper, as all of you know, we needs right thoracotomy, and for the distal third, we needs left thoracotomy. And obviously, if there is a perforation at the gastroesophageal junction, so we will be requiring upper midline laparotomy, and the things can be sometime managed through transhytally if the perforation is just distal, or the left thoracotomy can be added. And here are the few indications where we may have to perform esophagectomy as a rescue operation in a case of esophageal perforation, especially in case of tumor, for caustic perforation, untreated achalasia, and for caustic stricture. So there is a role of minimal access surgery for the repair of esophageal perforation. As you know, we are doing more and more transhiatal esophageal surgery laparoscopically, and the thoracic surgeon also are performing esophageal procedure, achalasia, and other things thoracoscopically. So it's a feasibility, and there are few centers who are regularly dealing these injuries laparoscopically and by thoracoscopic approach. So for surgical management of the esophageal perforation, laparoscopic and thoracic approaches are established, but only few centers are doing. So endoscopic stent placement and use of some these fibrin and sealing agent are also being used. So stent placement for simple perforation, small perforation with minimal or no contamination, it can be the mainstay of treatment. Whereas if there is some pleural effusion and involvement of the pleural space, then the chest intubation may be necessary along with stent placement. And last thing that I need to discuss, we need to understand the concept of damage control surgery in esophageal perforation. For perforation who present within 24 hours, because the primary surgical repair is the mainstay of treatment. Whereas for patients who are very sick and present late, in any way they are with high mortality and morbidity. So in those patients, sometimes definitive surgical repair is not possible. So in those patients, we need to apply the principle of damage control surgery. Okay, we do the debridement, drainage, control of the sepsis, antibiotics, and once the patient is out of sepsis and stable, then definitive surgery can be done. And there are no disclosures in this presentation. Thank you very much. If there are any questions, the panel will be able to answer. Thank you.